So I'm Marie Harvey, Associate Dean for Research here in the College of Health. And I'm delighted to see those of you in person and those of you coming in via Zoom. I'm going to introduce today our individual who's going to introduce our speaker and also moderate the session. So it is my pleasure to introduce Harold Bay, Dr. Harold Bay. He is an associate professor in biostatistics and has graciously agreed to introduce our speaker and to moderate the discussion. So hold on to your questions and we'll have a lively discussion at the end. And so passing it over to you, Harold, we're going to pass this around. We only have one.
Hello. Well, thank you for coming to the seminar today. And my name is Harold, and we are very grateful to have Dr. Anita Cservenka come here and share her research with us. It's a very interesting topic, and I'm very excited too. So one more thing before we get started, we have participants here in person in Halifax Center, as well as via Zoom. So if you're joining us via Zoom, for security, we are using a webinar feature. So your microphones will be muted. So if you have a question, please use the Q&A feature. And after the talk, we'll be moderating so that all of your questions will be read out to the audience and to the presenter so that your answers could be questions can be answered. And with that, I think we will get started, and thank you.
All right. Thank you so much. First of all, I'd like to thank Marie for inviting me here today. I'm really excited to be here. Thank you for the introduction, Harold, and Susan for helping to organize this. Before we get started on the actual research that I want to talk about today, I want to give you a little bit of background on myself. So I received my PhD at OHSU in behavioral neuroscience. So my research originally started out looking a lot at neurocognitive risk factors for substance use. So mostly what my research focused on initially was understanding how family history of alcohol use disorder increases one's own risk for developing alcohol use disorder in their lifetime. And then moving on, when I got here in 2016, I started to explore other substances. And so that's when my research on cannabis largely started. So since then, in the last 8 years, I've been doing a lot on cannabis, specifically trying to understand what are some predictors of problematic use, what are some correlates of problematic use. And this was particularly timely because in 2015, that's when Oregon legalized recreational use of cannabis. So first, I'll tell you a little bit about where we are today with the legal status of cannabis. So this is a map, of course, of the U.S., and it shows us that cannabis is currently legal for medical use in 39 states, and it's also legal for recreational use in 24 states. You might have heard some discussion that's been happening recently. There's been a movement at the federal level to reschedule cannabis from a Schedule I substance to a Schedule III substance. So what does this mean? Well, Schedule I substances include a category of substances that do not have any current accepted medical use. They're also considered to have high potential for abuse. So the current substances on this list, including cannabis, are things like heroin, LSD, MDMA. So this is a type of scheduling that requires a lot of oversight by several government agencies if you're trying to do research on these substances. And so now there's been discussion. There will be a meeting probably in a couple months. The DEA will hold on rescheduling cannabis to a Schedule III substance. And what are Schedule III substances? These are substances that have some accepted medical use, and they also have lower risk of abuse. So ketamine falls into this category, as well as acetaminophen and codeine combinations. So what this all means for research, particularly for individuals who are trying to research the acute effects of cannabis, would be less hurdles, really, to get approval to research cannabis. Currently, as a Schedule I substance, individuals need to get approval from the DEA. They need FDA approval. they need approval from NIH and their IRBs. So it can be a very lengthy process to study cannabis in the laboratory. Some workarounds to that are individuals who are studying cannabis from an observational standpoint. So they're not actually administering cannabis to individuals. They're maybe asking people about their cannabis use or observing individuals using cannabis in their own homes or through mobile laboratories as well. So there's a lot of change potentially ahead that will make it a bit easier to study cannabis. But the series of studies I'm going to talk about today are all asking people about their own self-reported cannabis use. So speaking of prevalence of cannabis use and where we are, if you're familiar perhaps with the Monitoring the Future survey, this is a large-scale national survey that's been going on for several decades, actually, and it's been tracking individuals starting in the 12th grade, so right around when they're 18 years old, all the way through several decades of life now. And each year they're recruiting about 20,000 people into the survey at the 12th grade level. And you can see on this particular figure, they started tracking in about 1988, and this is looking at prevalence of past 12-month cannabis use. So we saw a peak in reports of past 12-month cannabis use in 2022, and it still remains quite high with, about 40% of individuals, a little bit higher, reporting past 12-month use in that 19 to 30-year-old age bracket. So we consider these to be young adults. However, we're also seeing past 12-month cannabis use increasing in this other age bracket, so 35 to 50-year-olds. And we don't have a lot of data points from Monitoring the Future yet for this older age bracket, middle-aged adults, just because these people are starting to now age into that cohort. However, we're also seeing some increases in cannabis use when we consider daily use, right? Not just asking people if they used in the past 12 months, but are they using on a daily basis? And the way Monitoring the Future defines this is having people report if they're using at least 20 days in the past month. Okay, so this is again breaking up these age groups into 19 to 30, 35 to 50, 55 to 65. And we're seeing, particularly in that last decade, some significant changes when you look at 5-year and 10-year changes in the 19 to 30-year-old age group, but also in that 35 to 50-year-old age group as well. So daily cannabis use is going up, not just past 12 months. And so what does this mean? What risk could having more people reporting cannabis use mean? Well, individuals might be at greater risk for developing what we define as a cannabis use disorder. So clinicians would typically use the Diagnostic and Statistical Manual of Mental Disorders to conduct an interview and assess whether someone meets criteria for a cannabis use disorder. So there are 11 possible symptoms that individuals could report that are included on this list. So maybe they're disclosing that they are using cannabis in larger amounts than previously. Maybe they have unsuccessful efforts to cut down in their cannabis use. They're spending a lot of time using the substance. They experience craving or persistent ideation around using cannabis. Potentially, they've also given up activities that they've usually been involved in. It could be social activities or work-related obligation. And then some symptoms could include physical or psychological symptoms associated with tolerance or withdrawal as well. And so based on how many symptoms individuals endorse, 2 to 3, 4 to 5, or 6 or more, someone might meet criteria for a mild, moderate, or severe cannabis use disorder. And currently, it's estimated that about 3 in 10 people who use cannabis will have a cannabis use disorder at some point in their life. But prior to actually developing a cannabis use disorder, individuals might be engaging in patterns of cannabis use that we might consider to be problematic. Okay, so this actually could precede the onset of a cannabis use disorder. And of course, it could be present in individuals who are already diagnosed with a CUD as well. So what is problematic cannabis use? Well, we consider it to be a pattern of harmful use. And this pattern of harmful use might be associated with different social, health-related, academic or job-related difficulties. And we can actually ask participants to report on some problems that they might experience from using cannabis. There's been several scales developed for this, but one of the common ones used is the marijuana problem scale, developed by Stevens a couple decades ago. But it's a 19-item self-report scale that has people respond to statements about marijuana, and they do use the term marijuana for this scale, which is important because I'll talk about some other scales that use cannabis in their question. So again, it's asking people to respond to statements as to what degree marijuana, in this case, has caused them problems in the past month. And these are going to be in areas that are social relationships, potentially financial difficulties, physical health problems, or memory impairment. It could also be related to their productivity or motivation to complete tasks, particularly at work or in academics. And it could also include problems that are related to legal problems. So someone could endorse no problem in an area. They could have a minor problem, and they could also endorse a serious problem. So this questionnaire would typically be scored on the scale of 0 to 38, where you consider the seriousness of the problem as well. And I'm going to be using this a lot in today's talk, so I just wanted to introduce it to you here and provide you a couple of examples as well. So a statement might say something like this: has marijuana caused you problems in your family, to have lower productivity? Has it caused you difficulty sleeping? Has it caused you lower self-esteem, or to miss days of work or miss classes? So for the series of studies that I'm going to be talking about today, where we're looking at problematic cannabis use, they're going to have some things in common. Okay, so I'm going to be focusing on intrapersonal correlates of problematic cannabis use. So unlike other studies that might look at interpersonal correlates, might look at potential family and peer substance use and how that affects problems, or social or policy-related correlates, I'm going to be focusing on the individual factors or intrapersonal correlates across these three topics. So I'll discuss emotion regulation, distress tolerance, as well as cannabis use motives. All right, so let's start with emotion regulation. How do we define emotion regulation? So emotion regulation can be thought of as someone's capacity to respond to emotional experiences in an adaptive manner, and also control those emotional responses, have some inhibitory control over the emotional experiences that one has. And importantly, there's been a lot of research that suggests that difficulties in emotion regulation is actually a transdiagnostic risk factor for a number of different psychiatric disorders, including substance use disorder. There are also studies that have focused more on cannabis users as well, and they suggest that individuals who use cannabis experience difficulties with emotion regulation, and this has been also reported to be associated with problematic use. One study in particular also looked at what we call dimensions or facets of emotion regulation. So looking at something like emotional clarity as opposed to goal-directed behavior or impulse control or emotional awareness, which are different dimensions of emotion regulation that I'll be talking about as well. So this suggests that it might be important to continue to investigate emotion regulation as an interpersonal correlate of cannabis use. But also many of these previous studies didn't look at other individual differences that might moderate this association. And so I want to introduce an individual difference that may be important to look at. So monitoring the future in this case has also been collecting data on patterns of cannabis use across the sexes. And we see that there's been an increase of cannabis use, but also that this sex and gender gap has been closing over time. So previously, mostly what we've been seeing is that male individuals will report higher rates of cannabis use than females. And this higher rate of cannabis use has also been related actually to more problematic use. But this has been a decreasing gender gap over the last couple years, especially, it's actually flipped recently. So the last publication of Monitoring the Future indicates that females are reporting higher rates of cannabis use than males. Okay, so this is really important to investigate. One limitation I do want to mention for Monitoring the Future is it's only since 2022, I believe, that they started asking questions on gender identity. So that's something I'll talk about for future directions as well. But up until 2022, they were basically using binary sex variables and maybe, I think, had a third option for other or prefer not to answer. So the aim of the first study I'm going to talk about is looking at how sex may moderate the association between emotion regulation dimensions and problems associated with cannabis use. All three of the studies today come from the same survey data set, which is important. And I've also selected studies that use similar analytic approaches because I think that will make for an easier comparison across studies as well. So this survey was an anonymous Qualtrics survey, and it was intended to ask participants about their cannabis use patterns, characteristics, and mental health related questions as well. Participants were compensated with a $5 Amazon gift card. They were also entered into a raffle. They had the opportunity to then win a $100 Amazon gift card, or some participants came from the psychology subject pool and may have earned credit for participating as well. Some basic criteria we had were age of majority, U.S. citizenship, as well as fluency in English. So the participants who completed the survey and ended up in this sample were 741 past 30-day cannabis users, meaning they had to endorse using cannabis at least once within the past month. We had a lot of criteria before the 741 to exclude people who took the survey too fast, who may have had different responses to their cannabis use patterns at different points in the survey. So basically, individuals who weren't taking the survey seriously. The sample breaks down into 508 males and 233 females. And they were around their mid to late 20s on average, with a slight age difference here that's significant, males being around 28 on average, with females being close to 25. Past 30-day cannabis use was also about, on average, 10 to 11 days in the past month, with a non-significant but trending difference with males reporting more cannabis use in the past month than females. So I just wanted to introduce the difficulties in emotion regulation scale. If you're not familiar with it, this is a 36-item questionnaire that looks at 6 different dimensions of emotion regulation. And it has statements looking at individuals' capacity to regulate emotions, where someone can endorse a 1, meaning almost never occurring to them, or a 5, all the way up there to almost always. Higher scores on this measure indicate someone endorsing greater difficulties with emotion regulation. So the 6 dimensions the questionnaire focuses are non-acceptance of emotional responses. So this would be having like a tendency to have a negative reaction to one's own emotional distress. So a statement for non-acceptance would be something like, when I'm upset, I become angry with myself for feeling that way. The second is difficulty in engaging in goal-oriented behavior. So this is your difficulty in concentrating or accomplishing tasks when you're experiencing some type of distress. This would be a statement such as, when I'm upset, I have difficulty getting work done. The third category is impulse control difficulties. So this would be something that's difficulty remaining in control of your own behavior when experiencing negative emotions. So a statement would be, I experience my emotions as overwhelming to emotional responses. The fourth category is lack of emotional awareness. So for this would be a reflection of someone's lack of attention or awareness to their own emotional responses. So individuals might say they don't pay attention to how they feel. The fifth one is limited access to emotion regulation strategies. So someone might have some type of reflection or belief that they can't really do much about their emotions. They can't regulate them. So they are going to endorse something like, when I'm upset, I believe that I'll remain that way for a long time. And then the sixth dimension is lack of emotional clarity. This would be a reflection of an individual's knowledge about their own emotions. Okay, so if someone might endorse, I have difficulty making sense out of my feelings. So hopefully that gives you a little bit of sense of the types of statements that participants would read on this measure. And so now I'll talk again about the analyses we ran. There's some basic regression models. So we include sex and emotion regulation dimensions as main effects. And then we're also interested in looking at their interactions and how that's associated with problematic cannabis use. We have a number of demographic and substance use covariates in these models, including age, race, ethnicity, income, the highest level of education someone endorses, and their past 30-day cannabis use as well. Let's take a look at the results here. So here we're looking at those 6 dimensions of emotion regulation across 4 on the top here, 2 on the bottom. And I just want to highlight a couple of interactions that were significant among this group. So in panel B and panel D, we're looking at 2 dimensions: difficulty engaging in goal-oriented behaviors and lack of emotional awareness. So here we see a significant moderation. So male cannabis users have a significant relationship between reporting difficulty engaging in goal-oriented behaviors and problematic cannabis use with that marijuana problem scale that I showed you earlier. And we see the same pattern across panels A and C as well as E. Okay, so those are some of the other dimensions. And what this also suggests that while the interactions were significant, the slopes for females are also significant relative to 0. So I want you to just be aware of that. It's not to say that this relationship wasn't present in females. It's just that we have a stronger effect in male. What was interesting for lack of emotional awareness is we find a completely opposite relationship. Here, males who are reporting greater lack of emotional awareness actually also endorse fewer problems associated with cannabis use. So I found this to be really interesting, and I was trying to think about how we could explain this. Perhaps what's happening here is attending less to your emotion and not thinking about them as much might be something where males are not going to use reward-driven strategies than to engage in problems associated with cannabis use. So there's some potentially other ideas that might be present there, and I'm open to a discussion at the end about that. But the implications of these findings are that most dimensions of emotion regulation in this study, we saw that males had a stronger relationship between those dimensions and problematic cannabis use. It's possible that females are using more protective behavioral strategies when engaging in cannabis use, and there's some literature to support that. Females have also been shown to endorse greater knowledge of the health risks associated with cannabis use. And then that finding in panel D that I found to be interesting, it's possible that less attention or awareness of emotion in males may be related to decreased risk of problematic use. Perhaps, again, this could be explained by a focus on emotions that could otherwise result in engaging in behaviors that are more impulsive or more reward-driven. So these findings suggest that perhaps sex-specific interventions for emotion regulation strategies should focus on some distinct dimensions of emotion regulation rather than kind of collapsing emotion regulation into just one construct. Okay, so we'll move on then to the next study. So this study looked at another interpersonal correlate of problematic use known as distress tolerance. So let's define distress tolerance here. There we go. So distress tolerance can be thought of as someone's emotional capacity to withstand negative psychological states. And it's been an important construct because poor ability to tolerate distress has been associated with more negative consequences of cannabis use across several studies. But there hasn't been a lot of research to further examine individual differences in that relationship. So just to introduce again the scale that we're using, the distress tolerance scale is a 15-item questionnaire It looks at 4 different types of distress. And these are going to be statements regarding someone's, again, emotional capacity to withstand negative psychological states, with endorsing 1, meaning you strongly disagree with the statement, to endorsing 5, meaning you strongly agree. Higher scores for this questionnaire indicate lower tolerance to distress. So here are some examples of the 4 different types of distress that are measured by the questionnaire. The first is the perceived ability to tolerate emotional distress. A statement might read, I can't handle feeling distressed or upset. The second is a subjective appraisal of distress. That statement might read, my feelings of distress or being upset are not acceptable. The third is attention absorption by negative emotion. This would be when I feel distressed or upset, I cannot help but concentrate on how bad the distress actually feels. And then the fourth area is regulation efforts to alleviate distress. I'll do anything to avoid feeling distressed or upset. We use a total scale score for the distress tolerance scale, which is typical for this scale. And individual differences we were interested in examining here are how people report the different forms of cannabis that they might endorse as their primary or preferred form of cannabis. So the way we assess this is we have the daily sessions frequency, age of onset, and quantity of cannabis use inventory. This is a psychometrically validated questionnaire that has a number of different questions related to route of administration for cannabis, typical form of cannabis people use. And the question we took from this was, what is the primary form of cannabis you use? Where participants could choose between these options, flower, concentrates, or edibles. So if you're not familiar with forms of cannabis, so here are some images, up to head, of flower, concentrates, and edibles respectively. So concentrates are typically going to be the highest potency THC product. And there's different routes that people might administer concentrates. Sometimes you might have heard of something like dabbing, where individuals will be using concentrates with what's called a dab rig. And then liquids, which is going to be used via a dab pen, similar to liquids you might see used through a vape pen that individuals might be using for nicotine as well. Edibles are going to vary in terms of their THC potency, but typically their onset of psychoactive properties is going to be much more delayed relative to concentrates, which is going to be very immediate, as it would be for ingesting flower, which is going to be typically smoked through different routes. They can be smoked through a joint, a blunt, a spliff. There's various routes that people may endorse on the measure that we used, but I won't be talking about methods today. I'll just be talking about 3 different product forms. So the aim here was to examine if there may be an interaction between the primary form of cannabis someone endorses using, as well as how distress tolerance and hazardous cannabis use are related to each other. So we had a slightly smaller sample for this analysis based on the participants who actually completed these questions. We divided the sample up into those who endorsed each of these different primary forms. So we had 474 of 695 people endorse flower as their primary form of cannabis. Concentrates, we had 139 people endorse that. And then we had 82 people endorse that edibles were their primary form of cannabis use. So for the regression models here, again, similar analysis, making for an easier comparison. We have 3 different forms of cannabis that are looking at moderating the relationship between distress tolerance and problematic use. For our measure of hazardous cannabis use, we're actually using the Cannabis Use Disorder Identification Test as opposed to the marijuana problem scale here. And that's because of the language around these different forms. Many people only think about the term marijuana when they're thinking about cannabis flower. But here we're actually asking people about different forms of cannabis. And so by using the Cannabis Use Disorder Identification Test revised, we avoid any terminology related to marijuana. We have the same demographic and substance use covariates as previously indicated in the study I presented on emotion regulation. So what do we find here? here is our graph for the interaction, suggesting that the relationship between distress tolerance and problematic cannabis use is significantly moderated by someone's endorsement of the primary form of cannabis. And this is going to be true for those who are reporting marijuana flower or concentrates as their primary form. And we did not find a significant association between distress tolerance and problematic use for those who reported edibles as their primary form of cannabis. So some potential implications, individuals who are endorsing that their primary form of cannabis, the one that they're using most frequently perhaps, may enhance the relationship between reporting low tolerance to distress and problematic cannabis use. It's also possible that individuals who are experiencing lower distress might be drawn to these products more frequently, and that is why we see this relationship. So we can't really say for sure what that directionality might look like. And then for edibles, some of the characteristics of the sample who endorsed primary form of edibles, we saw that overall, they also had lower lifetime prevalence of cannabis use. They were less likely to use for recreational only purposes. They were more likely to use for medical only purposes. And there were also some slight demographic differences between the groups as well. But these could explain possible protective factors for individuals who endorse edibles as their primary form of use. All right. So lastly, we're moving on to the third study, where I'm going to be talking about individuals' motives for using cannabis. So why is someone interested in using cannabis? And people can have several different reasons they're using cannabis. So reasons might include coping, stress-related coping in particular. It might be social pressures. Maybe you're surrounded by friends who use cannabis. So you're thinking that you're trying to, use cannabis as well to conform to those pressures. Enhancement-related reasons. So that means like you're using cannabis because it makes you feel good, right? Euphoric-related reasons. You like the high that you get from using cannabis. So these could be all different motives, and most people actually endorse multiple motives for using cannabis, not just one single motive. What we've seen recently from a meta-analysis is that several of these cannabis use motives are related to problematic use, particularly coping motives. So many studies have looked at coping motives. That one seems to stand out as maybe one that's a highest risk factor for problematic use. So as I've been interested in sex differences, we also examined how individual differences related to sex might moderate this relationship. So similar to that first study I showed you. So I want to introduce our third questionnaire here, the marijuana motives measure. This is a 25-item questionnaire, and it's going to ask participants how frequently their own marijuana use is motivated by each reason, from a scale of 1 to 5, so 1 being never or almost never, to 5 being almost always or always. And there are 5 different motive categories for using cannabis. The first one is enhancement, so a statement might read, because I like the feeling. The second is expansion. So this is related to individuals' increase in wanting to expand their awareness, to be more creative. The third is coping. So that would be someone endorsing they're using cannabis for stress-related coping, to forget their worries. The fourth is conformity. So someone might endorse they're using because they want to be liked by their friends. And then the fifth is a social-related reason, because it makes social gatherings more fun. So just some data I want to show you looking at the comparison between the sexes in this study when endorsing different motives. Okay, so here are 5 motives in this table. Again, we had more males in this sample than females, but if we look at the overall average of these motives, we see that males overall are significantly higher on their motives across all of these except for enhancement. Okay. So the average scores for expansion, coping, conformity, and social are all higher in males relative to females. Here, we did not find a significant difference for enhancement-related motives. Keep that in mind for the analyses I'm going to show you. So again, our aim here is similar to the first aim that I showed you. We're looking at if sex moderates the association between these different cannabis use motives and problematic use. So there's two ways we ran this analysis, partly because a previous study had done something similar. We wanted to look at whether we could replicate those findings. And in that study, they combined all motives into one model. So they were interested in investigating if one motive might explain some relationship with problematic cannabis use above and beyond the other motives. We also looked at the motives separately as well. So we ran this first. We looked at the motives separately in each model and their interaction with sex, and then we ran this full model. Same demographic and substance use covariates that I've talked about before. So what do we find? Again, I've highlighted some of the important, interesting findings in these green rectangles. We found that when we ran the models separately for motives, for enhancement, expansion, and coping, we see that males have a significant association, more so between those motives and problematic use relative to females. Again, females have this relationship between motives and problematic use, but we have a significant interaction such that this is going to be more of an association in males across the sample than it is for females. Okay, so some of this is not surprising and actually matches with what we would have expected from the previous literature. Coping definitely supports the findings that we've seen before. But I want to point out some interesting results that we got from the full model. So when we combine everything into one model, we find that the only significant interaction that remains when you control for all other motives is the sex by enhancement interaction. Okay, so suggesting that this interaction is significant even when we consider all other motives that people have for using cannabis. So what does this mean? Well, we see that when we look at the motives separately, males have a stronger relationship between cannabis use, motives, and problematic use. For those same motives in particular. And then the sex by enhancement interaction suggests that use motives for males may be particularly related to the rewarding effects of cannabis, more so than they are for females. And so looking at these rewarding effects of cannabis as a particular target for prevention intervention studies might be really valuable when conducting those studies and examining these individual differences by sex. Okay, so I'd like to just summarize the series of studies that I went over. We first saw that certain dimensions of emotion regulation are more strongly associated with problematic cannabis use in males relative to females. We also saw some interesting relationships there where emotional awareness showed that opposite slope for males. Individuals who primarily report use of cannabis flower or concentrates may be at greater risk for this relationship between lower distress tolerance and more problematic use of cannabis. And then we also see that sex differences are present in cannabis use motives. And even though we saw a difference for all the other motives except for enhancement, the significant interaction in the end was for the sex by enhancement relationship. Okay, so enhancement motives might be a particularly important target when designing intervention studies for cannabis users and particularly for male cannabis users. So given these are studies that are cross-sectional in nature, right, we're collecting self-report data. The question here is, how can we use this data? How can others use this data to inform prevention studies, to inform intervention studies as well? So I'll give you some examples of some studies that have been conducted already that this research could build upon. We know, particularly from emotion regulation research, that if you look at mindfulness-based interventions, those seem to be really the strongest in terms of the effect sizes that we see for assisting with reductions in substance use across a variety of substances. So emotion regulation might be a really important target in mindfulness-based research. And for distress tolerance, there's only been actually a few studies that have looked at distress tolerance in intervention studies. This first one is called the Skills for Improving Distress and Tolerance. This was for patients who had substance use disorder. They could have had cannabis use disorder, but it could have been something else as well. And they looked at whether repeated exposure to negative mood states and practicing distress tolerance strategies might be able to modify and basically improve substance use treatment outcomes. They did find that there were significant improvements in distress tolerance compared to treatment as usual, but they didn't look at individual differences. So again, this is something that the current research could build upon by looking at how individual differences might modify this relationship. And then more recently, we see that there was a distress and tolerance intervention that was conducted in a different population, but they looked at whether this intervention could specifically reduce cannabis use frequency as well as symptoms associated with cannabis use disorder. And they did find that reduced distress and tolerance correlated with reduced cannabis coping motives as well as reduced CUD symptoms. So there's some promising work out there in these interventions. And then lastly, in the motives area, we see that when we look at coping motives in particular, that seems to be an important one for decreasing those types of motives, for reducing cannabis use, particularly when examining the outcomes with cognitive behavioral therapy. And we also see that across a longitudinal study, most motives tend to decrease over time across 15 months, except for conformity motives or non-treatment seeking samples too. So if you look at non-treatment seeking samples of adolescents who are undergoing motivational enhancement therapy, their cannabis use motives are also declining over the course of their treatment. So what are some future directions of this work? So I mentioned individual differences, mostly focusing on sex differences and forms of cannabis today, but a lot of this work can be extended to look at other individual differences. In my lab, I've been particularly also interested in sexual and gender minority populations. There's a lot of work that's ongoing, suggesting that internalizing symptoms can mediate the association between someone's sexual and gender minority identity and cannabis use. And then more recent findings suggest that a lot of these different interpersonal correlates might be used in the same model as well, right? So cannabis coping and emotion dysregulation have been shown to explain the association between minority stress and cannabis outcomes. I think it's also worthwhile exploring additional correlates of cannabis use. So looking at things like THC potency or dose, the quantity of cannabis that individuals are reporting, as well as substance co-use. So there's a student in my lab who's been very interested in psilocybin. We now see psilocybin use also increasing with decriminalization in Oregon. And so that's a growing area of research in my lab as well. And then ideally, designing a study that could actually track these types of motives or correlates over time would be really wonderful so that we can see how individuals' motives for cannabis use, how emotion regulation might change over the course of their cannabis use, particularly during young adulthood as we see those patterns of cannabis use being the highest within that age range. So finally, I'd just like to acknowledge a lot of support that I received for conducting this research, particularly from the School of Psychological Science, as well as previous funding that I've gotten from the Medical Research Foundation of Oregon. Several grad students who have led the projects that I talked about today Jess Cavalli, she's a postdoc now at the University of Washington, doing great work extending her knowledge in cannabis use to looking at substance co-use with individuals using alcohol as well. Another graduate student, Melissa Nahara, who led the project on forms of cannabis and how that moderates the association between tolerance to distress and problematic use. And then Chris Mullen, a PhD candidate in my lab, who has been looking more closely at cannabis use motives. I've also had a lot of undergrad students over the years, so I haven't been able to name all of them here, but the 4 listed here have been particularly helpful for the projects that I discussed today. I just want to thank my lab as well as the College of Health for hosting me today. Happy to take any questions that people might have. Yes.
I have 2 questions. The first one was what were the examples of the protective behavior strategies that you said females were using, or the paper said females were using?
Yeah, so protective behavioral strategies could include things like, I'm not going to use a certain amount of cannabis, right? I'm going to limit my use to a smaller amount. So it could be related to the quantity of cannabis you're using. You can make decisions also about the frequency of engaging in cannabis use. You can make decisions about not engaging in cannabis use before going to work or before you have to study for an exam. So they can be different types of strategies, and there are particular scales that have actually been developed from the alcohol research literature that have been used now for cannabis as well. And actually, my grad student, Chris Mullen, is going to be looking at protective behavioral strategies and how those actually might promote resilience, particularly for the relationship between cannabis use and academic performance. Does that answer your question?
Ask me a second question.
Sure.
Is there a reason you limited the studies to the survey to only U.S. citizens?
So that was a request from the IRB, actually, because cannabis is, well, not only federally illegal in the United States still, but also it's illegal in many countries around the world. And because of the international student population who might want to engage in the survey, we want to make sure we can protect individuals to the greatest extent possible in the event that this type of data would be disclosed. Yeah, thank you for asking that. There was another question.
I also have a couple of questions.
Sure.
First, was there any attempt to validate self-reporting, especially between the different sexes and genders? Because that could be tricky.
Yeah, self-report is really hard to validate, and I completely acknowledge that. So typically, we do collect the self-reported data through online surveys. There's no way for us to go back and ask in any different way. Like, we didn't do any urine toxicology tests or anything like that for this study. But I would say that in a lot of other studies I've done that are laboratory-based studies where we have participants actually come in, report on their cannabis use, and we do urine toxicology, it maps on pretty well. Like, if they say they're using cannabis, they test positive for THC metabolite. Now, again, that's not perfect because they might have used a long time ago. Those metabolites can remain in the body for a while. But that's really the only way that we can verify that in person, and really no other way we can verify that.
My second question is related to emotional regulation being correlated with cannabis use. And correlation obviously does not imply causation. And thinking back when I was young, decades ago, the people I knew who had emotional regulation issues were the ones who chose to use pot at the time. And one of their principal motivation was rebellion, which was not something that you looked at. And I'm wondering whether the whole idea, cannabis is not the problem itself, but it's a sign of an underlying problem, which could explain why treating the underlying problems reduces cannabis use.
Yeah, so there could be a lot of co-occurring psychopathology going on, absolutely. And in this survey study, while we collected data on other measures that look at depressive symptoms or anxiety symptoms, I didn't present that today. We didn't, do clinical interviews with participants. So it is difficult to tell if they have comorbid psychiatric disorders present. We had just basic criteria again for people to take this survey. So there's no way for us to be able to answer that. But again, going back to my lab-based studies, we do often exclude participants for psychiatric disorders that we want to make sure aren't, in some way interacting with the questions of interest. And we've done that in the past for those in-person studies.
Emotional regulation issues are not necessarily psychiatric disorders.
No, they're not necessarily.
Basically, which could explain why why men with low emotional awareness are low users, because they don't feel they have a problem to solve.
Yeah, that relationship was really interesting, finding that lack of attending to your emotions actually correlated with lower problems, right? And we didn't see that for any of the other dimensions. So I'm still trying to wrap my head around why not attending to your own emotions might actually mean that you are endorsing fewer problems related to cannabis use. Anne-Marie?
Oh, I asked the first question of since you just mentioned the distress balance. I think perhaps the strategies women may seeking more social support, which kinds of strategies, known elements, and strategies for decreasing the use of cannabis. And I have a question about the age. It's really the youths that are just into the adulthood period. There is a lot of things and the rules that are open to them, but they not just have enough skills dealing with a lot of stress that they are facing. So they might be age can moderate some issues.
Yeah, absolutely. We controlled for age in these models because age is oftentimes associated with more problems experienced from cannabis use. Participants here only had to be 18 or older for this study. They tended to be more young adults that completed the survey. But yeah, age is absolutely an important covariate.
There was this category of age and the prevalence that you mentioned at the first slide. So maybe this category can just take for example.
Yeah, if you were to categorize age and dichotomize it into different groups, yeah, you might see, that could be another variable you might look at for an interaction, right? Yes.
Interesting findings. Thank you for sharing. I just have two questions. The first one is you mentioned primary use of edibles were seen as a protective factors. So what was the exact reason? Why only use of edibles were seen as a protective factors and not other components? Did you find anything a rationale? Maybe I just don't. Maybe a reason to it. Why? And the second question is the sample characteristics. So maybe I missed it, but the participants were diverse across US, or was it only the majority participants were white, or were they African American and Spanish? How diverse was the sample?
Yeah, I actually have a hidden slide on that, so I can pull that up. But to answer your first question about why edibles might, be protective, I think it has to do somewhat with the sample characteristics that I talked about. These are going to be participants who are engaging in a bit less cannabis use on average, less frequent cannabis use. They're engaging in a way that's less risky, okay? They are also more likely to use for medical purposes and not just for enhancement related reasons or social related reasons. They had some differences that we might be able to get from the table I'll pull up on, also some demographic characteristics too. So I think these are just ideas that I had on why that relationship wasn't present between individuals for primarily endorsing edibles. But there could be other unmeasured right? Unmeasured variables that could explain that as well.
I'm just like having one idea. Like, do you think to like maybe conducting a small focus group with these participants to maybe get more deeper understanding of, I don't know, maybe it could be a something that you can look into, like, conducting like a small focus group to just get an idea that can help you to maybe form your arguments.
Yeah, I think that would be a great idea. Yeah, to talk to people who are primarily engaging in that form of cannabis. Like, how do they differ maybe from people who are, using flower principally or concentrate? Yeah, so I'll answer your question and then I'll pull up that demographics table. We can take a closer look at that.
I guess I have two questions as well. Seems like we all have multiple questions.
No, that's great.
So we know that most people use multiple forms of not just one of them. Did you, in any way, were able to control for that? Asking kind of selfishly because we have a study and like, when did it? And the second one is, concentrate is such a wide variety of things. So you can have vapes, which is like very easy entry. In fact, adolescents are probably more likely using vapes than the actual flower. But then you have dabs, which seems to be like extreme people who are already established users are using.
Yeah.
Did you have enough to kind of separate vape from other forms of concentrate to kind of see, as I think that would be potentially interesting, just because of how diverse concentrates are?
Yeah, that's a wonderful question. So unfortunately, we weren't able to, control for, multiple different forms that people are using, which is totally accurate, right? Most people don't just endorse, like, I only use flower. So that's really, really critical as a future study to see, are people who are reporting multiple forms of cannabis, if you control for that even, like, is one form maybe related to more problems still? And then, related to concentrates too, we didn't have specific questions in the DFAQ on routes of administration, because there's evidence from people who study concentrates that, there are routes that are associated with much higher risk and individuals who are further along in their trajectory of cannabis use. So that would be another question to add that, we didn't have present in the study.
So mine is a little probably well. Anyway, did you develop your surveys or did you use this?
Yeah, we used the validated surveys and then we looked at the internal consistency within our samples as well. And they looked pretty good. So, yeah.
Did I find really is really fun, but the challenge.
Oh, yeah. Yes.
It's always
Yeah. Yeah.
I noticed like it's 10 or 11 days. Did it show like, are they like primarily on the weekend? Does that even matter or even know if it?
Oh, yeah. So I think the DFAQ actually does have questions in there about weekday versus weekend use. I have not looked at that yet. As a potential like correlate there. But I think that's an actually.
So the participants, the survey participants, are they like local or where are they from?
So we think that most of them are from Oregon. We distributed the survey across, social media websites and such, but it's very possible that people could have sent the link, to someone outside the state. We didn't ask for a state of residency or anything like that. So we're uncertain like how widely it ended up being distributed, but the demographics that I'll show you actually suggests that the sample was relatively more diverse than what we would see just in Oregon. So that might suggest that people did send it around. Let me see if I can unhide this. If I exited, I might have messed it up. Let's see. I might have to share a different screen then. Yeah. Is it display on area too? Okay, great. So can anyone read this in the back, or is it way too small? Okay, let's see. I think I'm not going to be able to, unless I use this Zoom tool here. Okay. So here's some demographics of the sample. Again, mid to late 20s on average. About in the total sample, I think that's an easier column to look at. About 63% are not Hispanic, Latinx, 35% identify as Hispanic, Latinx, 65% roughly are Caucasian, 21% Black or African American, 5% American Indian, Alaska Native, 3% Asian. Then we have people who identify as more than one race, Native Hawaiian, Pacific Islander, and then the smallest categories there. So somewhat more diversity than what we might expect in Oregon. In terms of income, most people fell between the 50 to 75,000 gross income range there. And I can try to move this. So highest level of education, most people were either some college or a bachelor's degree. And then we have their substance use characteristics. More than half the sample endorsed more than 100 days of lifetime cannabis use. Age at first cannabis use tended to be in the early 20s. Most people were recreational only users. And yeah, 65% of the sample is endorsing cannabis flower as their primary use across this entire sample here. And then those are some other substance use characteristics on the bottom for alcohol and nicotine.
It does appear to be.
Yeah, so I think people definitely sent it around. Yeah. Yeah, question in the back.
Yeah, just a follow-up question to Dr. Bay's question, initial question. So I'm wondering if the survey is sent to different people in different states, it could also be interesting to look at if the legislations in Oregon, for example, maybe the House Bill of 3000 or ORS 375C. So those kind of policies can actually have like spillover effects in other states, in terms of seeing marijuana for medical use, for instance. So if we are able to measure like how many people had responses from other states where marijuana is not legalized for recreational use, then we can actually probably decide if that's a spillover effect from legalizing marijuana in Oregon to other states where marijuana is for. And the second part is, here's a rough question. Do you see the legalization of marijuana, for example, being an area of research that we should look into, especially across states and outside of US?
There's a lot of research on that. Well, actually,
Harold?
yeah, really, like economists are doing a lot of research in comparing states and rents and ones.
Yeah. So yeah, it's a really important question. And I was just going to say that Harold Bay does a lot of research on that with a colleague of mine in psychology, David Kerr, on the effects of legalization. So very important. And I think you're also absolutely right that in future surveys, if we can do this and the IRB is okay with it, we can ask people about, like, are they at least living in a state where there's medical use that's been legalized, recreational use that's been legalized, or neither? Without identifying state of residency, just to get a better idea of that. Again, I only looked at interpersonal correlates for this study, but we have the societal level correlates that are also very importantly related to cannabis use outcomes. And there's more research now that suggested that, the legalization of cannabis may be increasing cannabis use, and maybe there's substitution effects going on too, where people are decreasing their alcohol use in exchange for increasing cannabis use.
Right. Well, thank you so much for coming to the Friday seminar. Well, thank you.
Thank
But
you, everyone.
Paul, I think we all learned a lot. So yeah, this is it, and enjoy your long weekend, I guess, right?
Thanks, everyone.